Today we're going to cover Chapter 3, Epidemiology, the study of disease, injury, and death in the community. Here are the chapter objectives for Chapter 3. After studying this chapter, we will be able to define terms such as epidemic, endemic, pandemic, epidemiology, and epidemiologist, and explain their importance. We will also be able to list some diseases that cause epidemics. We'll discuss how the practice of epidemiology has changed since the days of Benjamin Rush and John Snow, and explain why rates are important in epidemiology. We will also be able to define incidence and prevalence rates and provide examples of each. We'll be able to discuss the importance of disease reporting to a community's health and describe the reporting process. We'll also be able to define the following standardized measurements of health, such as life expectancy, years of potential life lost, disability-adjusted life years, and health-adjusted life expectancy. We'll be able to identify some sources of secondary data, describe the two main types of epidemiological studies, and finally list the criteria used to evaluate whether or not a risk factor causes a disease. When you become ill and visit a doctor, the first thing the physician does is take measurements and collect information. These measurements include your temperature, heart rate, and blood pressure. The information includes time of onset of your illness, where you have traveled, and what you might have eaten. Next, you may be given a physical examination and be asked to provide a specimen, such as urine or blood, for laboratory examination. The information gathered helps the physician understand the nature of your illness and prescribe an appropriate treatment. While a primary care physician is concerned with the health of an individual patient, you, an epidemiologist is concerned with the health of a population. They monitor health at a population level, and this is important because it helps determine when unexpected or unacceptable levels of health events occur, such as illness, injury, or death. And when this happens, epidemiologists seek to collect information about the health status of that community. So here we're going to go over a couple main points in the introduction. Right? Epidemiology is the study of medicine for the population, so it's not at an individual level like doctors. Epidemiologists are concerned with the course of a disease in a population. So where did it begin? How is it affecting people now? And when will it end? And they collect information about the disease. How many people are sick? Who is sick? When did they become sick? And where do they live? And this data can be used to prevent disease outbreaks or determine effectiveness of prevention efforts. Although epidemiology was originally applied to infectious diseases, its application has expanded to other areas, including, but not limited to, chronic diseases such as diabetes and cancer, reproductive health issues such as infertility and preterm births, environmental health concerns such as pollution, and occupational hazards such as asbestos exposure, and understanding health disparities in disease risk and outcomes. Epidemiology is defined as the study of distribution and determinants of health-related states or events in specific populations. An epidemic is an unexpectedly large number of cases of an illness, specific health-related behavior or event in a particular population. An endemic is a disease that occurs regularly in a population as a matter of course. So an endemic is expected, like the flu. And then a pandemic is an outbreak over a wide geographic area. Here we have a table of notable epidemics in the United States. In the first column, we see the disease name. In the second column, the cases in previous years. In the third column, the epidemic period, how long it lasted. And then the last column, the number of cases. If we look at the second to last row, we have the 2009 H1N1 virus, or influenza, which actually started from pigs. This strain was previously unknown to the United States, and it lasted a year, from April 2009 to April 2010. There are an estimated 60.8 million cases, and there are 12,469 deaths. This influenza disproportionately affected young people. We can look at the current outbreak of acquired immunodeficiency syndrome, or AIDS, HIV/AIDS. And this is another example of a pandemic. So it started in the late 70s and really took off in the 80s. As of now, there are an estimated 1.2 million people that have died from AIDS worldwide, and about 36.9 million people living with AIDS right now. The number of new HIV infections has declined 35% since 2000. Here we have a picture of people during the influenza pandemic of 1818 to 1819. People are talking about this a lot now that we have the current COVID-19 pandemic occurring. You can see that even in the early 1900s, people figured out that you should wear masks. Right? This disease spread in Europe, Asia, and North America simultaneously. An estimated 25 million people died over several years as a result of this pandemic. When we talk about the history of epidemiology, the concept dates back to Hippocrates in 300 BC. Hippocrates is also known as the father of medicine, and even then he was suggesting a relationship between the occurrence of diseases and the physical environment. For example, he thought that cases of a disease fit the description of malaria, which we know to be malaria now, were found to occur near marshes and swamps. So he's already connecting malaria, what we call malaria now, to an area where mosquitoes are prevalent. With the fall of the classical civilizations of Greece and Rome and the return in Europe to a belief in spiritual causes of disease, few advances were made in the field of epidemiology. As a result, epidemics continue to occur, and there were 3 waves of plague, one in 542 to 543, one in 1348 to 1349, and another in 1664. There were also epidemics of leprosy, smallpox, malaria, and later syphilis, and also yellow fever. Here we have a little bit of information about yellow fever. So yellow fever struck Philadelphia in 1793, causing the death of 4,000 people. Yellow fever again hit in 1797, 1798, and in 1803. Dr. Benjamin Rush, who was a prominent physician in Philadelphia at the time, and he's also one of the people that signed the Declaration of the United States, was able to trace the cases of yellow fever to the docks where ships arrived from tropical ports. However, his conclusion was that the disease was caused by vapors arising from decaying coffee beans in port warehouses. Not surprisingly, he was incorrect. He could not have known that yellow fever is caused by a virus and is carried by the yellow fever mosquito. These facts were discovered by Major Walter Reed of the U.S. Army and his associates a century later. In 1849, some 50 years after the yellow fever outbreaks in Philadelphia, cholera became an epidemic in London, and this is where we really start the epidemiological history with John Snow. Now we're going to start talking about actual epidemiological numbers and figures. Okay? So we're going to start with the rates. Now we're going to go through a lot of these different types of numbers, and it's really important that you pay attention, look up extra resources if I don't explain it well enough for you, or ask questions, because it is important to be able to distinguish between these types of statistics. You will really need to understand this for your assignment and if you want to be health literate in the future. So rates allow for comparison of outbreaks at different times or in different places. For example, by using rates, it is possible to determine whether there are more cases of gonorrhea per capita, right, per person, this year than there were last year. Or we can determine whether there are more homicides per person, per capita, in city A than in city B. But in order to do this, the population that is at risk must be considered. Okay, so the population at risk means that you have to be able to get the disease or the condition. Okay, so for example, a really simplified example is I cannot get into a car accident if I never enter a car, right? I have to be in a car to be in a car accident, okay? I have to have a uterus in order to get uterine cancer, okay? So that is rates, and rates is really just the number of events, okay? So we often talk about it in terms of birth, cases of a disease, or number of people with the disease, or deaths. And there are three general categories of rates. We have birth rates, also known as natality rates, morbidity rates, which means sickness, and mortality or fatality rates, which means death. So the number of cases is simply the number of people afflicted, or those who are sick. So the exact number, okay? And then again, rates are the number of events in a given population, people that are at risk, over a given period of time or a given point in time. And again, we have three different types of rates. And then finally, here we have population at risk, those that are susceptible to a particular disease or condition. Again, just like I have to be in a car to get in a wreck, or I have to have a uterus to get uterine cancer. Next, we're going to cover incidence and attack rate, and then we'll go on to prevalence. So the incidence rate is the number of new health-related events or cases of a disease divided by the population at risk. Okay, so the incidence is the new number of cases. It's really important in the study of acute diseases or short-term diseases, okay, things that don't last a long time. Diseases in which the peak of severity of symptoms occurs and subsides within days or weeks. So this could include the common cold, the influenza, the flu, chickenpox, measles, or mumps. Second, we have the attack rate. The attack rate is the incidence rate calculated for a particular population for a single disease outbreak, and it's expressed as a percentage. Okay? So here we could say 80% of those with diabetes, right? Diabetes is the particular population for a single disease outbreak, were affected somehow, right? 80% of those with diabetes developed this condition. Fill in the blank. For example, let's go over an example. Suppose a number of people who traveled on the same airline flight developed a similar illness. An epidemiologist suspected that the cause of this illness was associated with the flight itself. An attack rate could be calculated for their passengers on that flight to express the percentage who became ill. So we could say 80% of those that were on the flight became ill or were affected. Furthermore, the attack rate could be calculated for various subpopulations, such as those sitting in the front of the plane, in the middle of the plane, towards the back of the plane, or those who ate the chicken on the plane, or those who had the water. Okay. Or you could even go into particular age groups. Only the children were affected, or only the elderly were affected, etc. So that is an attack rate, breaking down a particular population. Differences in attack rates for different subpopulations might indicate to the epidemiologist the source or cause of the illness. So again, if we found that only the people that drank the water were affected, we could start to assume that the water was the source of the issue. Next, we have the prevalence rate, and this is the number of new and old cases in a given period of time divided by a total number in that population. So this is the number of all cases in a given period of time divided by the total number in that population. And this is very useful in the study of chronic diseases, or diseases that usually last longer than 3 months. So some common examples would be heart disease, arthritis, cancer, or diabetes. With these diseases, it's hard to determine the onset time of the disease. Right? You don't just suddenly wake up one day and have arthritis or cancer, right? It's a slow progression. It's difficult to pinpoint a cause. So with these diseases, it's more important to know how many people have it instead of how they got it. And this allows us to create facilities, distribute resources accordingly. Here we have a table that breaks down how exactly they're calculated. So you have incidence rate, attack rate, and prevalence rate. Again, I would refer to this figure when writing your assignment. Now, the interpretation of rates is very important to understand. Right? A lot of people see these kind of health statistics and assume they know how to read them, and they're often wrong. Okay? So incidence and prevalence rates can be expressed as crude or specific. So crude rates are the rate in which the denominator includes the total population. So everybody that's at risk is included. However, age-adjusted rates are used to make comparisons of relative risks across groups and over time when groups differ in age structure. So there are a lot of diseases that are more prominent in elderly individuals, right? So it would make more sense to adjust the rate to reflect that outcome. So it's not very likely that you will develop dementia or Alzheimer's disease at a young age. So often these rates are age adjusted. Okay? 80% of people 70 years old have Alzheimer's, etc. That's not an accurate statistic, by the way. So here we have an example of accrued and age-adjusted mortality rates for Alaska and Florida from 2012. Okay, so these are mortality rates, the number of people that have died. To show what the level of mortality would be if the age composition of different populations were the same, epidemiologists use age-adjusted rates. For example, in 2013, because of its larger senior population, Florida had a higher crude death rate of 926.3 per 100,000, compared with Alaska's 543.7 per 100,000, where the population is younger. However, when these death rates are adjusted for differences in age structures of the population, one can see that the death rate in Florida, which then becomes 663 per 100,000, compares favorably with the death rate in Alaska, 724 per 100,000. So once you adjust for the larger elderly population in Florida, the numbers change to become more representative. Physicians, clinics, and hospitals are required to report births, deaths, and notifiable diseases. The notifiable disease is an infectious disease for which health officials request or require reporting because they can often lead to epidemics. So these diseases are reported, and the birth rates and death rates are reported to the CDC via the National Electronic Telecommunications System, or NETS. And there are various challenges to maintaining accurate data, but reporting them to one major location helps with this. This is a list of some of examples of notifiable diseases. The list is significantly longer than this, but I just pulled out some that you might recognize. So anthrax, malaria, measles, mumps, cancer, chlamydia, foodborne disease outbreaks, hepatitis, plague, rubella, salmonella, smallpox, tetanus, typhoid fever, etc. If you want to see the full list, you can just write notifiable diseases CDC and you'll find that. Here's the layout of how notifiable diseases, the schematic of how they're notified. So doctors, clinics, and hospitals report to the local health department, who report to the state health department, who then report to the CDC. Now we're going to go over some standardized measurements of health status. So first we have mortality statistics. This is the most reliable measure of population health status, right? How many people are dying in your population. In 2013, there were 2,596,993 deaths were registered in the United States. The crude mortality rate, right, including everybody, was 821.5 per 100,000. But the age-adjusted mortality rate was 731.9 deaths per 100,000. Life expectancy is defined as the average number of years a person from a specific cohort is projected to live from a given point in time. So life expectancy is completely based on where you live, right? We're going to look at some examples. So here's life expectancy at birth at 65 years of age and at 75 years of age according to sex in the United States during the selected years. Okay? So at birth, we're going to start at the top left. At birth in 1990, if you were born then and you were male, your life expectancy would be 46.3 years. And for females, it would be 48.3. Then the average would be 47.3. If we jump down, straight down to 2013, at birth, the average life expectancy is 78.8. And that's about where we are now. Okay, 78 years. As you might notice, females almost always have a higher life expectancy. If you go over to the middle columns, your life expectancy at 65 years, how many years do you have remaining? Right, increased as time goes on. And at 75 years, it does the same thing. So as we progress, we're living longer. So again, for reference, the United States has an average life expectancy of 76 to 78 years. So this data is from 2013. And this is life expectancy at birth for some selected countries by sex. Okay? So you can see a couple of examples. India, we have 65 years for male, 68 years for females. Nicaragua, 71 for males, 77 for females. And if we go down to the Republic of Korea, we have 78 for males, 85 for females, which is a large difference. So you can see that there are usually quite a few years between males and females, and this can be broken down even further than country. Right? You can look up by county what the life expectancy is. And Mississippi is a really good example because we have some extremely impoverished counties that have significantly lower life expectancy, and they can be neighbored to a wealthy county that has a higher life expectancy. So it really can be broken down very thoroughly to even neighborhoods. Now, years of potential life lost refers to the number of years lost when a death occurs before one's life expectancy. So if my life expectancy is 78, which is the average, and I die at 75, then I have lost 3 years of potential life. Okay. So you subtract the person's age at death from his or her life expectancy. And again, this changes depending on your gender and where you live. It's difficult to determine because life expectancy changes at different ages. So age 75 is often used in calculations. And this weighs the death of a young person as counting more than the death of an old person because they've lost more years of potential life. Disability adjusted life years, or DALYs, measures the burden of disease. So 1 DALY equals 1 lost year of a healthy life. Health adjusted life expectancy refers to the number of years of healthy life expected, on average, in a given population or region of the world. So as we get older, the number of our healthy years decreases. Right? So on average, right now in the United States, we have 11 years of health decline towards the end of our lives. Right? So if the average age is 75, then from 64 on, our health is expected to decrease and decrease and decrease. Now we're going to talk about sources of secondary data. So secondary data is the data collected by someone else, probably for another purpose. So primary data is when you collect the data yourself. So if you've ever participated in research, you probably have collected data yourself. And secondary data is data collected by someone else. So it's really useful in planning of public health programs and facilities because we have these very, very large data sets out there that the country uses. So one example is the U.S. Census. So George Washington actually ordered the first census in 1790 for the purpose of apportioning representation to the House of Representatives. Through the years, the census has become much more complex than the one filled out more than 200 years earlier. Data are gathered about income, employment, family size, education, dwelling type, the type of house, home you live in, or where you live, and many other social indicators. Copies of the U.S. Census results are available in most libraries and online at census.gov. Census data are important to health workers because they are used for calculating disease and death rates and for program planning. The U.S. Census is carried out by the Bureau of the Census, located in the U.S. Department of Commerce. So, in summary, what they do is they enumerate the population. They count every single person, or they at least try to. It's taken every 10 years in our current censuses going on right now, and it gathers data on race, age, income, employment, education, and where they live. Another source of secondary data is a vital statistics report. And vital statistics are summaries of records of major life events such as birth, death, marriage, and divorce. It's published by the National Center for Health Statistics under the CDC, and it also calculates death rates by race and age. Lastly, we have the Morbidity and Mortality Weekly Report. So again, morbidity is diseases, and mortality is deaths. So it's prepared by the CDC from state health department reports, and it reports morbidity and mortality data by state and region of the United States. It reports outbreaks of diseases, environmental hazards, unusual cases, or other public health problems. We also have national health surveys. The National Health Survey Act of 1956 authorized continuing survey of amount, distribution, and effects of illness and disability in the United States. Now, there are 3 types of surveys. You have health interviews of people, where you go possibly from door to door and ask people about their health. You have clinical tests, which are more objective and less subjective. Right? You take blood pressure, you measure their weight, you measure their BMI, and you complete a physical examination. Or you have surveys of places where people receive medical care. So for example, hospitals have lots and lots of secondary data, right? They record everything. So I can actually look up a hospital and pull data from there. So I can see how many people were discharged, how many people had this kind of surgery, how many people stayed for a week or more, right? So there's lots of data out there. We also have some more national health surveys, such as the National Health Interview Survey, which is conducted by the NCHS, and it questions respondents about their health. We also have the National Health and Nutrition Examination Survey, which is called NHANES. This is a very commonly used secondary data set for research, and it assesses health and nutrition status through mobile examination centers. So they actually drive around and collect survey data. They actually take objective measurements such as blood, BMI, etc., and they even do some cognitive tests, so they can test people's memory or their abilities. Then lastly, we have the Behavioral Risk Factor Surveillance System and the National Healthcare Survey. The Behavioral Risk Factor Surveillance System measures different risk factors for different ages. So there's a youth-specific one, and in this one they ask questions such as, are you sexually active? The last time you had sex, did you use a condom? How many sexual partners have you have you had in the last month? Have you ever used a cigarette? Have you ever done drugs? Right? So they ask all these questions that are very personal but very, very informative. So the Behavioral Risk Factor Surveillance System that we just mentioned is actually state-based, and it's by a telephone. There's also a Youth Risk Behavior Surveillance System, which I just mentioned, and it uses students through 9th and 12th grade and monitors 6 categories of health. And then lastly, we have the National Healthcare Survey, which gathers information on the nation's healthcare system. And this helps healthcare providers, policymakers, and researchers answer questions about resources, quality of care, and disparities in service. Now we're going to talk about epidemiological studies. So these are investigations carried out when disease or death occurs in unexpected or unacceptable numbers. So we have descriptive studies and analytic studies. Descriptive studies describe epidemics with respect to person, place, and time. Okay? So they're just looking at the issue and describing it, right? So if I have a class of 10 people, this is a simple example, and 6 of you have colds, right? I'm just going to describe it. Out of these 10 people, 6 of them have colds, 3 of which are female. They're all college aged, right? This person lives here, this person lives here. So I'm not doing anything to my sample, I'm just reporting on it. And then we have analytic studies, which are aimed at testing a hypothesis. So they do manipulate the situation. So again, descriptive studies describe epidemics. They answer who. They develop a case count followed by who is ill, right? Children, men, women, what race are they, etc. When, they discover the time of onset for each case, and they create an epidemic curve. And they work on where. So determine residential address and travel history. So these descriptive studies are very important and useful, but they also have some limitations. So descriptive studies are usually not applicable to outbreaks everywhere, right? So when we talk about COVID here, right, our results from COVID, what we're seeing in the United States, does not apply to other countries, right? It applies to what we're doing here. Also, the investigation of a single epidemic cannot provide information about disease trends. And then lastly, with few exceptions, descriptive studies by themselves rarely identify the cause of an outbreak. So they can begin the process of determining a cause. Maybe they can just gather some information that sheds some insight on the situation, but they cannot say what caused the cold is being female, because all the people that have a cold in my class are female, right? That means nothing. It's just descriptive. So epidemic curves are graphic displays of the cases of disease according to the date or time of onset of symptoms. So we have single epidemic curves, which can be used to calculate the incubation period, the period of time between exposure to the infectious agent and the onset of symptoms. Okay, so how long does it take once I've been exposed to COVID for me to start having symptoms? That's the incubation period. Common source of epidemic curve is the point source and the continuous source. So analytic studies, unlike descriptive studies, test hypotheses about relationships between health problems and possible risk factors. So within analytic studies, we have observational studies and experimental studies. Observational studies is where the investigator observes the natural course of events, noting exposed versus unexposed and disease development. So if let's just stick with a sample of 10 students, right? I have 10 students in my sample. Nobody has a cold yet, but what I am keeping an eye out for, what I'm interested in, is seeing who develops a cold. So I'll follow these 10 students, not literally, but I'll keep track of them. And then once they develop a cold, I'll write it down and write down where were they, who did they talk to, right? When did they start developing symptoms, etc. So I'm just observing. And then within an experimental study, an investigator allocates exposure and follows development of disease. Okay? So they actually do a lot of really interesting studies on colds and what they can do to give people colds, right? They can put some of the virus, like swab it in your nose, in your nasal cavity, and see who develops a cold, right? So here I'm actually giving participants a disease, right? So another example of an analytic study might be one designed to discover whether cigarette smoking, which is a possible risk factor, is associated with lung cancer, which is the health problem, or whether improperly prepared food, a possible risk factor, is associated with an outbreak of salmonella, which is the health problem. It's important to remember that the association discovered through analytic epidemiological studies are not always cause and effect associations. Okay? So it takes a lot of work to show cause and effect. Okay? And we're going to talk about that later. So other experimental studies are carried out to identify cause of disease or determine effectiveness of a vaccine, drug, or procedure. The central feature of an experimental study is that the investigator can control the intervention or variable of interest. For example, groups of study participants could be followed after receiving different medications or being asked to adhere to different diets and to see which interventions were most effective. A lot of these experiments also implement a control or a placebo effect. Now, placebo is a blank treatment. So if my experiment, I was working on a cure for cancer or some headache medicine, right, I would give everybody medicine. Doesn't matter what group you're in, everybody's receiving some type of medicine. It could be a low dose, a high dose, or it could be a placebo. The placebo would just be like a sugar pill. It would not affect you whatsoever, right? It would just be a fake treatment. And again, there's a lot of interesting information out there about placebos. I highly recommend you look it up, right? But a placebo usually needs to be implemented to make sure that it wasn't just by chance that your medicine worked, right? So now we're going to talk through what it actually takes to determine causation. The example we're going to stick with is smoking and lung cancer. So what we need to do is we need to question the exposure. How does smoking cause lung cancer? Okay. So first we have to meet these variety of criteria. The first one, which is strength. Okay. Now strength discusses how strong is the association between the exposure and the disease. Okay. So how strong is the association between smoking and lung cancer? Are those that are exposed, or those that smoke, 3, 5, 10, or 100 times more likely to develop the disease than those who are not exposed? How many times more likely are cigarette smokers to get lung cancer than non-smokers? Also, is there a dose-response relationship? Is it the case that the greater the exposure to a particular risk factor results in a higher rate of disease or death? For example, are those who smoke more heavily more likely to develop lung cancer than lighter smokers are? Next question is consistency. Has the association been reported in a variety of people exposed in a variety of settings? Are the results repeatable by other researchers? Then we have specificity. Is the disease or health problem associated with the exposure the only one? Is smoking the only thing that can cause lung cancer in this example? When someone becomes ill after exposure, is it always or almost always the same disease? When cigarette smokers become ill, is it always or almost always lung cancer? Temporality. Does A, the exposure, always precede B, the disease? Does the behavior of cigarette smoking precede the onset of lung cancer? Or do those with lung cancer take up the habit of smoking for some other reason? Okay, so we have to have A come before B, or it doesn't make any sense to cause it, right? Then we have biological plausibility. Does the suspected causation, smoking, make sense with what we know about biology, physiology, and other medical knowledge? Does it make sense, in light of what we know about biology and physiology, that cigarette smoking could produce lung cancer? These criteria are guidelines rather than rules. They should be considered along with careful interpretation of epidemiologic studies and other evidence. Using these criteria, together with analytic, epidemiological data, health researchers can often persuade legislatures and public officials to pass laws or alter public policies that promote health. In the next chapter, we'll examine how epidemiological studies can be used to prevent and control diseases and health problems in the community. Lastly, here are some discussion questions to think about. How can data collection for notifiable diseases be improved? Why is tracking vital statistics so important? And how does calculating years of potential life lost change the way we think about community health efforts?